Welcome, everyone, to this second seminar in the Joint Research Office seminar series. Welcome to those of you here in Lecture Theatre 2 at the John Radcliffe Hospital, and also welcome to those of you who are joining us online. We've got a very large number of colleagues registered to join this seminar, so we're really pleased with the interest, and we look forward to the next hour being informative and interesting. And I'm sure it will be, because the topic we have for today's seminar is of critical importance to all of us involved in clinical and translational research. Even those of us who try to insulate ourselves from the news will not be unaware of the major changes that are happening in the NHS and in our healthcare delivery systems. And as translational researchers, our research ultimately has to be aimed at making clinical impact and benefits for patients. If our research is going to do that, it has to be implemented, and the impact of that research has to be realised through a healthcare system. We can't do it on our own within a university or a research setting. And in that context, the setting up of the integrated care systems, which are run by integrated care boards, is a critical and relatively new aspect of the landscape and the infrastructure in which we work. Of course, that's all been complicated by the very recent major changes in the way the NHS is being organised, and perhaps I should say reorganised. And if we as researchers are unaware, then we miss massive opportunities. We should be choosing our research priorities to some extent based on knowing what are the needs in our healthcare. And our colleagues in the integrated care systems and who run the integrated care boards, they need to know what research is coming through, so that together we can get the best impact. In other words, we can make sure that our research has the anticipated impact on patient care. So today is a really excellent opportunity for us to hear firsthand from senior leaders from the Berkshire, Oxfordshire and Buckinghamshire Integrated Care Board, Bob. And it's a great pleasure to welcome Nick Broughton and Hannah Iqbal, who are going to speak to us about that for the first part of this seminar. And then we're going to invite our panel members. We've got senior research and clinical leaders from all of our partner organisations in Oxford who are going to join us as part of a discussion panel, and will answer any questions from the audience and questions that are put forward online. So before I hand over to Nick, who's going to start, perhaps I could just remind you of some of the housekeeping points. No alarms are anticipated, so if there is one, it's real. We're going to record this session. Please do concentrate on what's being said and submit any questions via the Mentimeter, which is here. It's in the programme. I'll give you a few seconds to take a picture of the QR code if you haven't got it already. And we will be looking at those questions in real time during the panel discussion. So thanks for that. Nick and Hannah, thanks so much for making time to join this seminar. It's really great to have this opportunity to hear from you directly. I think, Nick, you're going to come up first and then Hannah. So thank you very much.
Excellent. Keith, thank you for that. And Chris and colleagues, thank you very much for the invitation to join you today. I've been rather looking forward to this, actually, not least because it's a nice change from some of my sort of normal work, which is very much focused on NHS finances and reorganisation, as Keith has just highlighted. Just want to say a bit about me, because I think it helps set the tone, really, and not least, hopefully, will convey my commitment and indeed the commitment of the ICB as an organisation to working more closely with our partners in research, our academic partners across the system. So I'm a psychiatrist by background, specialised in forensic psychiatry, and before becoming the ICB's chief executive, I'd been chief executive of 3 community mental health providers, most recently Oxford Health, which, as colleagues in the room will be aware, hosts a biomedical research centre, one of only 2 in the country that's focused on brain health science. And Oxford Health also hosts the Applied Research Collaboration. So that role, I think, in particular, gave me some really valuable insights into, the complexity of the academic infrastructure that we have locally, but also the potential of the academic ecosystem that we have. And certainly one of the things I'm very keen to realise as the ICB's chief executive is that we harness that potential. We harness the potential for innovation and research that is around us to address some of the significant operational challenges that we have within our local NHS. So, Bob, I must admit, I'm not particularly a great fan of the acronym Bob. It's at times difficult to try and make people take us seriously when we sound a bit like a cartoon character, but we are where we are. Bob stands for Buckinghamshire, Oxfordshire and Berkshire West. So there lies one of the problems. We're not the most natural of systems, and obviously people do question why on earth we don't have all of Berkshire in the system. But there are changes afoot, and my colleague Hannah might cover some of those. But it's a system that we currently work within, and the Integrated Care Board is a key part of the Integrated Care system. The board came into being as a statutory entity back in July 22. We're one of 42 integrated care boards across England, so essentially the NHS in England has been divided up into 42 systems. I like this infographic because it highlights, A, the complexity of the system in terms of the organisations within it, but also, I think, the great potential that we have within our system, not least because we have 5 universities, obviously University of Oxford, Oxford Brookes, but other universities in both Buckinghamshire and Berkshire. And we are lucky to have 5 universities in our system for many reasons, not least because those universities together train virtually every type of healthcare professional that our provider organisations and primary care employs. There's a couple of AHP professions that we don't train locally, but the vast majority of other healthcare professionals are trained locally. So again, it builds on what I said earlier about the potential that we have within the integrated care system. And clearly, what we all want to try and achieve is that the whole is a good deal greater than the sum of its parts. Integrated care systems have really 4 key roles. One is obviously improving outcomes for our population. Linked to that, tackling health inequalities. Absolutely a major focus for us, and I'll come on in a second just to highlight some of the health inequalities that we have within our system. Quite marked health inequalities, actually, given the fact that people often think of our patch of the country as being very affluent. We are affluent in many parts, but not universally so. We also have a responsibility to enhance productivity across healthcare and also deliver value for money. And then linked to that, supporting the broader social and economic development of the geography we serve. As I mentioned, we came into being in 2022, so still a very new organisation. It's fair to say we've been through a fair amount of churn in those 3 years, and that's reflected by the fact that I am the 4th chief executive to lead the ICB, and we've had 4 chairs as well. Not ideal. Hopefully now we've achieved a bit of steady state in terms of leadership. We sit alongside an integrated care partnership that was also set out in statute. The partnership includes representation from all our local authority members. We've got 5 upper tier local authorities, also the voluntary community and social enterprise sector, the VCSE, really important and will become increasingly important as we look to the future and look to how we can deliver services within a strained financial envelope. And again, we are lucky in this part of the world in that we have a very thriving VCSE. And it also includes representation from the Health Innovation Network, another key academic partner. The system is made up of obviously provider organisations, our 5 trusts, and the ambulance trust, obviously primary care. But what we're increasingly focused on is how we can bring those entities together to create effective collaborations that can better meet the needs of the population. So we have provider collaborative. So Oxford University Hospitals, for example, is a member of the acute provider collaborative, working alongside the Royal Berks and Bucks Health Trusts. Similarly, we have a mental health provider collaborative that's brought together our 2 mental health community trusts. place is a word we use frequently. It's used a little loosely, being frank. It's not my favourite word in the lexicon. But when we talk about place in Bob, we're talking about the three core geographies that make up our system. So Oxfordshire, Buckinghamshire and Berkshire West. Berkshire West is comprised of Reading, Wokingham and West Berkshire. And those are important entities, not least because there's a strong sense of place, not least driven by our local authority partners, but also people understand what we're talking about when we talk about the county of Oxfordshire. And there's a lot of infrastructure that's developed over time at a place level. And then linked to that and sitting within our places, obviously we have neighbourhoods. And there's an increasing focus nationally on neighbourhood health and how we can support local populations, particularly through enhancing the primary care offer, through the ongoing development of primary care networks, and indeed the development of integrated neighbourhood teams. So that's another important part of our developing infrastructure. Our mission is to ensure that we deliver fairer, more sustainable services that improve people's lives. It might sound a little trite, but it's absolutely front and centre to what we're about. And that word sustainable is absolutely key. And any of you who've followed the NHS's travails in recent times will be aware that there are significant challenges facing healthcare services across our country. We've been spending an increasingly large amount of money on healthcare, but haven't been delivering improved outcomes. And the way services are configured, both here, but indeed nationally, is no longer financially sustainable. And that means we need to look very quickly at how we can transform, how we can change services, how we can introduce different models of care that A, deliver better outcomes to patients, but B, are affordable in the short, medium and indeed longer term. So the ICB has a key leadership role to do in relation to that, and we have a legal responsibility in terms of arranging healthcare, particularly commissioning services, so deciding what we want to fund and where we want to fund particular services. So we're responsible for the allocation of the NHS budget across Bob. This year we received almost £4 billion, so not a small amount of money. And essentially we fund everything that the NHS provides in Bob, apart from some of the more specialised services delivered by this organisation and by some of our other provider organisations. But indeed, that also will change in a not too distant future. And we have a responsibility linked to that regarding overseeing the delivery of services and driving forward improvements in services. We also are responsible for a variety of services we actually deliver, not least all-age complex care. So those are the packages of care that patients with complex physical and mental health needs require to keep them well in the community, often having been in hospital for acute treatment. And we have a variety of responsibilities in relation to supporting our colleagues in primary care, in relation to the infrastructure that primary care requires, in relation to the governance arrangements that primary care requires, for example, in the safeguarding space. For our population, we have about 2 million people living across the three places that make up Bob. Our population is a little older than national average, and when we look to the future, which we have done recently through some very detailed work that Hannah led, we expect the population to become increasingly elderly and to see a significant increase in the over 65s. And that is obviously important because it's that group of our population that use the greatest amount of healthcare. By and large, disease prevalence is a bit lower than the national average, although there are certain conditions which are more common in Bob, for example, atrial fibrillation, cancer and depression. I mentioned earlier about areas of deprivation, so by and large we're fairly affluent, but there are pockets of significant deprivation. And we have some of the areas in Bob which rank alongside the most deprived communities in the country, Blackbird, Leeds being a local example. And not surprisingly, those deprived communities are high users of emergency services and experience typically the worst health outcomes. This figure of 24% of our population accounting for about 3/4 of our spend, that's not unusual. You'd find that in virtually every system across the country, but it's a really important figure to consider when we come to planning services. And being frank, historically, we have not been great at targeting services where there is the greatest need. And if you map out where we have services, where we have primary care provision, for example, and where we have the greatest healthcare needs, the two maps do not overlap. And linked to that, we know, and again, the diagnostic work has helped clarify this, that we have significant variation in service delivery and in outcomes across our geography. Unwarranted variation that's developed over time as a consequence of a lack of strategic commissioning and a lack of understanding of need, and also custom practice, local innovation, local leadership, etc. I touched on this just a second ago about how we expect our over 65 population to grow significantly over the next 5 years. Linked to that, we expect the frail population to significantly increase. Again, it's that group that are one of the greatest users of healthcare. And we also expect the prevalence of cardiovascular disease to increase significantly as well. So when we look at this and we think about the resource that will be required to continue delivering services and to improve outcomes, there's a huge gap. And if we carry on doing things as we are doing, we estimate that that financial gap will be in excess of £700 million by the financial year 29-30. Again, reinforcing the need for change, for significant transformation, for reconfiguration, for service consolidation. That very much sets the scene as to why we need to work as closely as possible, and indeed far more closely than we have done historically, with our academic partners. And one of the things I'm very grateful about is this is an opportunity to help develop that conversation, to ensure that we can harness the ability in this room and beyond to help address some of the key challenges that we have going forward. But before we get on to that, I'm going to hand over to Hannah, who's going to talk about how our world's changing somewhat.
Thank you, Nick. And hello, everyone. I'm Hannah Iqbal, Chief Strategy Digital Transformation Officer at the ICB. And it's lovely to be here today, not least because before I joined the ICB, I worked in AUH for 4 years. So I must say I'm glad not to be in my office that I used to have on the corridor up there, because on a hot day like this, it was a bit of a nightmare. So I'm going to talk a little bit about, Nick set the scene for how ICBs were set up, but we're on the kind of precipice of change, probably in the next kind of week or so, where we're going to see some revised guidance on how ICBs change within the context of the new government and the 10-year health plan. So it feels a bit odd to say everything's changing in the NHS, because I think all the NHS knows is change. Nick and I were talking to an MP this week, and he said the more he works with his communities and in Parliament, the more he thinks that the biggest thing we should do in the public sector is help people raise their tolerance of dealing with change and how we manage change. And I thought that was really insightful. And so on this slide, we've got information around the changes that are coming in local government. So you may have seen some of the reforms around devolution, social care, and the reorganisation of local authorities. And then in parallel, again, you will have seen probably in the news, the abolition of NHS England. We've had an ask for integrated care boards to cut their costs by, on average, 50% across the country. And organisations like AUH here today have been asked to cut costs in the growth of corporate roles. And all of this is around the context of the financial sustainability of the NHS, but also more strategically, the 10-year health plan, which is hopefully going to be published in June. And so the 10-year health plan is all about the government's health mission to improve health and deliver 3 key strategic shifts: sickness to prevention, hospitals to communities, and analogue to digital. And I don't carry around much paper anymore, but I'm quite sad. And I carry around this folder with me, which is the Darcy Review, which is effectively the analytical foundation for the 10-year plan. And so Lord Darcy this review, and it's published online. You can just search Darzi 2024. And effectively, it's a really clear, evidence-based analysis of where the NHS is, where the challenges are, and some of the reasons that have led to that, not least the pandemic, but also some of the reforms and the structures, including the way ICBs are set up, that have maybe led to duplication, ambiguity, etc. So I'd really recommend reading that. So if that's the diagnostic, what we're going to see in the 10-year plan is the kind of solution moving forwards. And this is my kind of guess of how things will shape up. But I am in the slightly surreal experience at the moment of working with NHS England to define the future of ICBs, and something quite similar to this graphic will be in some national guidance released imminently. So effectively, what we're going to see is a single aligned centre with the Department of Health and NHS England coming together as one. There'll probably be some legislation in 2026. And the responsibility of the national team will be on national strategy and policy and kind of do once functions, so data platforms or probably life sciences. And then we expect to see a strengthened regional tier. So there'll be a stronger focus on performance and quality oversight. And some of that will shift out of ICBs. We're probably going to see fewer ICBs focused on strategic commissioning. And that alignment of the ICBs will most likely happen in line with the local government reorganisation I mentioned earlier. And then providers will see a kind of reform of how they're managed. So there'll be stronger focus on board accountability for the delivery of performance, quality and finance. And then finally, a lot of the 10-year health plan is focused on neighbourhood health and delivering integrated care close to home. So again, in the Darzi review, it talks about the NHS structures which are currently suboptimal and need revising. And I've brought out some quotes on this slide that particularly relate to the role of ICBs. So Nick mentioned earlier that as ICBs are currently constituted, we have some strategic roles, we have some delivery roles, and effectively we have Excel spreadsheets worth of statutory responsibilities that don't all necessarily make sense together. And I think what we're going to see is a streamlining of the focus of what does it actually mean to be a strategic commissioner, to use your population health budget to best effect, to deliver best value for your population. And so some of the quotes on this slide draw out that over recent years, the NHS has focused a lot about effectively technical efficiency, how we might improve processes and efficiency of what we do, but focus less on allocative efficiency around are we making the best decisions with the resources we've got? Are they based on evidence? Are we evaluating them? And how can we do that better? So I think this is going to be the emphasis that we'll start to see for ICBs moving forwards. So again, Sir Jim Mackey is the new transition CEO of NHS England, and he said that ICBs have a critical role to play in the future as strategic commissioners, and that's going to be central to realising the ambitions of the 10-year health plan. And so in terms of what strategic commissioning is, and I think it's really important in terms of linking to our conversation today, given the centrality of evidence to this, I would summarise it in kind of three main components, although it's effectively four. Number one is around, do you really understand your context, the population you're serving, the services that are on offer, and how your population's needs are going to change over time? And can you use that understanding of your context to develop data-led population health strategy? And that needs to be future-looking. It needs to include forecasting, modelling, and some understanding of how things are going to change over time with technology. Once you've got that foundation, how do you then coherently use your levers to deliver your strategy? So Nick's accountable for £3.6 billion. And so how can we be sure that we're using that to best effect to meet the needs of our population? And how can we embed that in our ways of working in a way that is more strategic than kind of rolling over big contracts that we've always had in place, but maybe actually are now quite outdated for the kind of care we want to deliver? And then finally, we need to get a lot more rigorous around measuring impact. I don't think the NHS, in terms of service delivery and commissioning, is great on evaluation. And this is something where I think there's a lot of opportunity to work more closely together. So this needs to obviously be around public and patient involvement, real understanding of return on investment, and then the cycle needs to conclude in terms of informing future provision. So if we were going to kind of guess, what capabilities does an ICB need to be the ICB of the future? I think it's about greater alignment with research, academia, innovation, commercial partners to enhance capability, to build our understanding of population health, to embed data analysis and BI. We need to be a lot stronger on health economics and the measurement of value. And I know there's colleagues in the university who've got a lot of expertise on that here in Oxford. We need to identify opportunities of new technology, and we need to be much more rigorous about how we're evaluating new models of care. Sometimes the NHS has been a bit fluffy with thinking just because something's in the community, it's better, but it might not be. And how would we know? And we can't actually afford to not know. We need to know. And then we also need to be less precious about scaling what works, because a lot of what you'll read in the Darcy review is that the variation across the country is quite shocking. And why in certain areas have they decided that actually this approach to managing diabetes is got really good return on investment, really good population outcomes, but everywhere else is kind of not really applying it. And there's a sense that actually we just need to be a lot more pragmatic and scale what works. I won't spend long around our kind of priorities, but we'll share the slides later. But this links a lot to what Nick's already shared and what I've built on in terms of strategic commissioning. I just wanted to end with a slide that the team have made around how we might align more in this new context with research partners moving forwards. So we need to think about evidence-based commissioning. We need to have a much more rigorous focus on what our priorities are. We need to think about the areas of alignment and then maybe focus and work together on those and keep going. Sometimes we kind of start things and they fizzle out because the landscape's so complex and everyone's so busy. And I think we can get a lot more rigorous, as I've said, in terms of how we might manage some work jointly linked to priorities and how we might incorporate evaluation. So I hope that's helpful. And I think I'm going to hand over to Keith.
Thank you very much, to Nick and to Hannah. Those were extremely comprehensive, but also very clear presentations. I'm sure we've all found them extremely helpful and useful in understanding what I think for many of us has been not a very clear context, and understanding it is the first step towards working with you. So we're going to move now on to the panel discussion. So please could I invite our panelists to come up onto the stage here. And if you can sit to the left of Hannah. Thank you all. Please do continue to submit questions via the Menti app. And first of all, I'm just going in a moment to ask our panel members to very briefly introduce themselves. There'll be lots of time to say more, but if we could just introduce yourselves, and Adrian's decided that Cam's going to start, and that's great. Cam, do you want to just set off and just briefly go on the line and say who you are?
Sure. I'm Cam Bowie. I'm a Professor of Psychiatry in the Department of Psychiatry and the Nuttall Department of Primary Care Health Sciences at the University of Oxford, and linked to the Trust also. I'm the Director Designate for the ARC, which would commence 26, and we can do it.
Hi, Helen McShane. I'm Professor of Vaccinology at the University of Oxford. I'm an infectious disease physician at the Oxford University Hospitals NHS Trust. I'm Director of the NIHR Oxford Biomedical Research Centre, and I'm Deputy Head of the Medical Sciences Division within the university.
Hello, everyone. My name's Paul Carding. I'm the Director of the Oxford Institute of Applied Health Research, which is based at Brookes. We have a large funded portfolio of research in applied health, which covers and includes a large majority of the professions of allied health and nursing and midwifery, as well as health research in general.
Hello, I'm Vanessa Raymond. I'm an old age psychiatrist and associate professor in the university and R&D director for Oxford Health. Very large portfolio of work going on around mental health and particularly dementia. We have the only UK's dedicated mental health and dementia CRF in the country, doing increasingly complex trials and early phase trials, especially in dementia.
Hello, I'm Adrian Banning. I'm a professor of cardiology here in Oxford. I'm the director of R&D at the OUH.
Great, thank you. Well, thank you all once again. Just to reiterate, we've got the senior research leaders from across all of the Oxford partners, including some of the major NHR infrastructure programs. So this is our opportunity to perhaps hear from our partner organisations before we turn back to Nick and to Hannah, asking for how Bob might respond to that. But perhaps we could start off before turning to the questions on just hearing from some of you, or all of you, if we've got time. What is the perspective from our research partner organisations right now on the importance of the integrated care system and how we anticipate working with them? And I'm going to start, if you don't mind, with Helen, because I've thought about maybe going furthest away from what is integrated care delivery, which is discovery research. And Helen, you direct the BRC, which has a focus really on experimental medicine, discovering new things, perhaps in an ivory tower. How do we make the work of the BRC and other discovery research programs, of which we're so proud in Oxford, how do we make that sit with what we've heard about from Nick and Hannah?
Yeah, Keith, so it's a really important question, actually, and we are extremely keen to work with Nick and Hannah to try and understand how we can do exactly this. So the BRC does focus, as you say, on, if you like, the early stage of translational research, experimental medicine, testing things in small studies, in proof of concept. And, you know, there is a sort of pipeline by which that progresses out through into real life, real world deployment. But I think some of that pipeline we can jump, and we can look at whether we can use the primary care settings, the community settings, to actually do some of that experimental medicine. I'd be really excited to explore how we can do proof of concept experimental medicine, not in a high-tech CRF in a ivory tower, but actually in a community, in a nursing home, in a primary care, in someone's home. And I think there's a big space there that we are not yet exploiting. I mean, looking at the NHS priorities, and of course we're all focused on those, the obvious one is the analogue to digital, and thinking about some of the work we're doing in our digital health theme from hospital to home, where we're really trying to move some of the work that we've been doing with using devices and wearables in a secondary care setting, in ITUs, etc., and moving that to how can we use those in the home to really to help healthcare.
Thanks, Helen. That's a great start. Really, really good. Adrian, I guess OUH is the biggest acute trust in the patch. I think that's right, Nick, but certainly we look to as the major. You know, OUH has this duality of responsibility, which is it has to provide acute care for the people of Oxfordshire, but it's also proud to be a university hospital. So we're trying to. So how, Adrian, do you as R&D director see the role of the ICBs, and how does it help the work of OUH, but perhaps also open up some new opportunities for research?
Yes, it's a difficult question, Keith. But I think what I would start off by saying is I think the trust as a hospital has a clearer alignment with research than it's ever had.
Yeah.
A closer relationship with the university than it's ever had. And in the 30 years you and I have been here, it's come together extremely well. That said, when we are on the challenges that we have, it can be a situation where research gets a bit of a battering. It can be the sort of soft option, really. And I think one of the responsibilities for us as the sort of research leaders is to try and make sure that research is seen as a way of facilitating solutions to problem, not arguably being part of the problem. And I think that is a challenge for us. I think it's been difficult, perhaps initially, as Nick mentioned, to get integrated with the ICB because there's been a lot of change there. I would like to see perhaps a better sense of ownership of all of the problems that we have in this area. And I think one of the problems that it has as a geography is the geography keeps changing, and the relationships therefore are difficult to cement. But perhaps this is a great opportunity for us to really get a better sense of connection with the community and with colleagues in different organisations, and really move that agenda forward. And that's kind of how I look at it and how I kind of perceived those presentations, which I enjoyed.
Thanks, Adrian. Really helpful. Vanessa, I mean, I guess as the R&D director from Oxford Health provides not just mental health care, but also community health care across a broad geographic area. So I guess we might expect that Oxford Health already has a clear vision of how it might work effectively with the integrated care system or even systems. Do you want to give us your perspective from Oxford Health's point of view?
Yeah, absolutely. I mean, I think, as you said, it's telling, isn't it, that the people that we see in our trust cover all of those key 3 priorities in the 10-year plan for the NHS. The increasing need to think about prevention, increasing elderly people thinking about how we can use digital resources, and I would say wider biomarkers. I mean, I think one of the very exciting things that's happening in mental health and dementia research at the moment is the fact that we have the possibility of using new biomarkers to detect disease earlier, particularly things like blood biomarkers, which are increasingly accessible to a wider population. But that presents opportunities, obviously, in terms of being able to diagnose disease earlier and offer treatment and support earlier, but also challenges, because if you're diagnosing people earlier, potentially you have a larger group of people that you need to support, and you need to think more about how you start to institute prevention and real prevention strategies if you're diagnosing disease earlier in the pipeline. I think what Oxford Health's done a lot over the last few years is look at how to develop new types of clinical service. So we've called them research clinics in the broad sense. We have a number running, a brain health clinic. That's one of about 20 or so across the UK that are being funded by research money, but also innovations in psychosis. So things like using biomarkers to identify responders to antipsychotics or non-responders earlier. So again, we can think about targeted intervention, improving cost and resource use, but also outcomes for patients. I think what we need to think about is how we work with the ICBs to develop more of those pilots, which I think are largely very efficient, but then how do we bridge the gap to commission services? Because I think that's the real challenge, and it comes back again, doesn't it, to that point of needing further evidence, but also being fairly proactive about rolling things out if we're starting to see a benefit early on, and not, as I think you said, Hannah, kind of getting too fuzzy in our outcomes and thinking, well, we won't do anything now.
Great, thank you very much for that comment. I think I might ask Cam to speak next, but Vanessa, you've really exemplified this idea that research isn't something we do at full cost necessarily, because it can benefit clinical care delivery. And if we can combine a research question with an innovative way of delivering care, then both sides can benefit. I often see translational research as sitting in a research lab, which is very large. It's not in square meters, it's in hundreds of square kilometers, and hundreds of thousands of people live in that lab. And to me, the ICS gives us a bigger research lab to do bigger experiments. But of course, if you give a scientist a huge lab on day one, they don't quite know where everything is and they don't know how to use it. So I think there's an element of learning how to use this living laboratory in which we all live, both personally and institutionally. And I think, Vanessa, you're starting to give us some insights into how Oxford Health has made that work. So, Cam, you've put together the latest bid for funding from NHR for the ARC, which is explicitly about applied health research. And we look forward to that being successful and you being the director of it. But you, therefore, would presumably have really quite a tangible expectation of working with the integrated care system.
Oh, completely. Yes, absolutely. So the next ARC is entirely about implementation and impact and knowledge mobilisation. That's quite a tough ask, really, because we know a lot of things that work, but we don't implement them. And some things aren't quite ready for implementation. But NHR and HSC really are focused on implementation at scale, not just in one corner of a county or in one city, but across the whole geographical area. And further than that, they want cooperation across the country for scale up. So this is going to happen. All other ARCs are in a similar position. We've had to reconfigure the way of thinking that we've had before. We haven't got lots of little pilot studies going on. The discovery science is really important because it leads to paradigm shifts and savings in different ways. It takes a bit longer. And research is made up of many, many different approaches and methodologies. So when Nick and Hannah have decisions to make, if we haven't got the best evidence, if we haven't got the best evidence as in trials, we will generate evidence which is acceptable and good enough, really, to make decisions around that. That's how policy works. That's how it's going to work for the ARC in the future as well. So we're closest to the front line, I guess, and I think we are and we're happy to be the delivery vehicle of the ICB's research activities and strategies and bringing together a coherent framework. All of this requires really able, skilled people. So capacity development is a big part of the ARC's activities, about 25% of the budget, probably more actually, probably about 35%. We need collaborative leadership. We need systems leadership where people can cope with the uncertainties of rapid change. It's going to be a very agile, dynamic system, and those rapid feedback loops are essential, and we have to be able to respond to them. So the ARC, again, for the first time, has built in some response mode activities. So if suddenly something happens, we can't say we're locked in for 5 years, I'm sorry, we can't help you. We are going to have to shift, and we've got capacity built in to do that. The third element, which is addressing Nick's point around inclusion and inequalities, that there's a big push in the ARC to address ethnic inequalities, social deprivation, poverty, and people who are at the intersections of multiple forms of disadvantage, because they're the groups that require a lot of healthcare. Aging well is central to what we're doing. Starting well, mothers and children, living well, living with multimorbidity if you're working, and of course dementia. So all of those themes are in there, but research inclusion and tackling health inequalities are an essential part of our DNA. And then the final point is voice, giving voice to people who are the intended beneficiaries of our ecosystem and structures, and making sure that we listen to those voices and we have a feedback loop which takes account of what they say as opposed to invalidate what they say, because it's quite stressful being in these positions and trying to deliver stuff. But we're going to have to change the pace and tone of those conversations. I find lived experience experts help me resolve dilemmas in evidence, but I also find we have a better conversation when they're in the room because we remember what matters. So all of those are different elements. I can't cover all of it. It's about a 190-page document, which is very dull in most places, but I think that's the nuts and bolts of what we're trying to do. So we're very happy to work with the ICB and looking forward to it and the rest of the infrastructure.
Thanks, Cam. So, Paul, thanks for being patient. One of the reasons for coming to you last is that we're now segueing into the questions that are popping up on Mentimeter. And obviously Oxford Brookes has made an absolutely huge contribution to our joint working across the Oxford partnerships because of the massive contribution you make to allied health professionals and their involvement in research, both supporting research but increasingly leading research. So it'd be great to get your perspective on how development of the allied health professional workforce and Hannah have laid out. And just before I hand over to you, this in fact is the topic of one of the questions which we're going to come on to next. How do we encourage non-medical staff groups to get involved in research as they are always underrepresented?
Thank you. Thanks for that question. That's made my life easier. I can't help listen to what Nick and Hannah have to say about prevention and about care in the community and health delivery in the community without thinking that the people that are going to be doing that are going to be the types of people that I'm talking about, the nurses, the midwives, the allied health professionals, the extended roles of those people, if we're going to make it financially viable. And we have made reasonable and substantial developments in research capacity and capability in those professions at a tertiary level, at a hospital level. And there's a lot still to do, but we have made progress and continue to make progress. I would have to say that if we look at community, if we look at the ICB in its broadest sense and its multiple locations, etc., I would say the research capacity and capability infrastructure for all of those professions that we're talking about is a very, very early stage. And I can't help thinking that without strategic planning for that and emphasis on those people that are at the coalface, not just in terms of research delivery, but in terms of formulating the research questions and indeed leading work streams where appropriate, we are, as a nation, let alone as a region, have a lot of work to do there.
Thank you. Thank you very much indeed. So it's been great to hear all of your individual perspectives. I think we've already had a really excellent conversation. There's quite a few questions stacking up on Menti, which I'm going to try and get through as many, but rather one by one, I'm going to try and bring out these. Panelists, this is also your opportunity to ask Nitin another question. So just put your hand up if you've got something you want to ask, because we've got them here. Let's have that conversation on the stage as well as via Menti. One of the top, having Nit and Hannah, I've been giving you a book back. Not that's already about resourcing. So your resource is being, if anything, reduced. You're being asked to do, as far as I can see, almost everything related to healthcare delivery. What is your statutory responsibility to support research, and is that going to be resourced in the context of diminishing opportunities to pay?
That's a very good question, and one that I can't definitively answer until we're clear as to what the model ICB will look like. And there's work in train. There's a document that we're hoping to receive tomorrow, which hopefully will shed a little light on exactly what our responsibilities are. I think it's likely, though, that we will continue to have a responsibility in relation to harnessing research capability within the system we lead to address the key healthcare challenges that we have within the system. In terms of resource, though, the resource is limited. ICBs across the country have had to reduce their running costs to the tune of 50%. We were told about this about a month and a half ago. That reduction has to come into effect by the third quarter of this financial year, which begins in October. So we clearly are going to have less money available than we currently have. So I think this means we have to think quite creatively. It also really highlights the importance of developing relationships with system partners. And that's why I think sitting on this platform today is incredibly helpful, because, we have a richness in terms of our system partners. And actually, we are all pretty aligned. We all want to do the same thing. We all want to create the best possible healthcare services. We all know that to do that, we need to embed research. The ambition has to be having research run like a golden thread through all healthcare delivery. We know that research benefits patients, not least in terms of their overall experience. We know it benefits people working in healthcare, not least in terms of their job satisfaction, and therefore helps us retain people. We also know that research is a way of generating a bit of income. And that's something I'm very keen that we look at, because I think there's huge opportunities, as we've touched on, to think about how we can harness the patient population in its entirety and use that for clinical trials, for example. And income generation will become increasingly important because the NHS finances are incredibly strained. So, in essence, we haven't got very much money to throw at this. It's very small pots of money, but we have lots of capability across the system. So it really is about harnessing that capability.
Mm. And either you, Nick, or perhaps Hannah, several of the questions relate to how Bob, as one of the integrated care systems, relates to other integrated care systems. We could do great things in our own region. Are there examples of, or how do you anticipate working with either neighbouring or indeed other national ICSs?
Yeah. One of my beefs really about the NHS is that we don't really have an NHS. The word national is used incredibly loosely, and it's a very fragmented system that's been created since 1947. But we are where we are. Certainly across the South East region. The South East region is one of 7 regions in NHS England. We work increasingly closely with the other 5 systems. They're Hampshire and the Isle of Wight, Surrey, Sussex, Kent and Medway, and Frimley. I think it's accepted by those other 5 systems that we are quite lucky in having the University of Oxford, obviously, but the rest of the academic infrastructure that we have in Bob. And certainly I think there's a desire to ensure that research and innovation is spread more effectively across the South East. Being frank, the relationships we have with other regions are not very strong. Which is a little bizarre because we're not that far from the southwest. In fact, I think we're about 50 miles from the southwest here. We're not that far from the Midlands. And I think that is something that needs to be addressed through central leadership. But again, I think the government is increasingly aware of the importance of ensuring that academic centres of excellence have a reach and an impact that extends far and wide.
Yeah.
And my ambition is that our system is the best system of its kind in the country. And we are seen as a centre of excellence in terms of how we've harnessed academic capability and capacity, and that people come to Bob and come to the constituent parts of Bob to learn. And I think we should be excited by what we can potentially deliver and achieve, because certainly when I look at our system and I look at the component parts, I look at the universities, the provider trusts, primary care. We've got great primary care relative to most other parts of the country. We have potential in spades, and the challenge for the leadership community is realising that potential.
Yeah. Vanessa's got a comment, I think, but while you're handing the microphone on, I'm sure that's right, Nick. That really chimes with me, because some of our very successful research programs have national reach, and that's exemplified by both our BRCs but also other major research programs which we're very proud of. They could be a way of forming some of those links at the service delivery level, and indeed making those national research programs even more impactful by linking into the ICS infrastructure. So that's a really important point. Vanessa, did you have a comment or a question?
I did. I had a comment and a question.
Please.
So, Nick, you were talking, obviously, the difficulties of managing decreasing resources, increasing needs, and obviously also supporting research to address those needs. I'm going to speak about dementia and old age services because it's the area I'm the most of. Obviously, lots of opportunities at the moment with new drugs on the horizon, but also challenges. I'm aware that there are a lot of industry partners that are already putting a lot of resource into pilot projects to improve infrastructure for delivery of things like biomarkers and potentially drugs if they are approved by NICE. How much does the ICB think there's a lever potentially to work with large industry and smaller companies to improve the infrastructure of services in these types of areas? Because I think it's a potential massive opportunity. But I'm aware there's sometimes some sensitivities about the NHS working with private companies, but curious to get your views.
Vanessa, thank you. So I certainly would be very keen to explore those opportunities. There are indeed sensitivities, but let's be frank, the NHS works extensively with private providers of one kind or another. We're highly reliant on the independent sector for elective care, and the government have reinforced the need to work effectively with the independent sector in terms of reducing waiting lists. So what you outline, I think, is something that we would be very keen to explore. Have we done that? No, we haven't, and in part because we haven't really had the bandwidth today to do that. But going forward, we need to look at all opportunities. We need to look at all capacity that's available to us. And we need to think differently, not just in terms of those sort of areas, but across the board. Because as I indicated in my sort of opening few words, the status quo is no longer fit for purpose. It's no longer affordable. So we need to change things and change things pretty quickly.
And just to build on that, I think with a couple of the recent questions around, I think we're going to move to integrated care boards having a much clearer set of metrics, outcome metrics they're held to account for. And actually, if the job of an integrated care board is to improve population health, then it's almost up to the integrated care board to decide what's the best way to do that, which partners are we going to work with, and also it will drive consistency across the country. Because if I hear about a ICB over there that's got a great evaluation process or something, I may as well not design my own. I may as well use theirs, in the same way that I think it will just be easier to scale things up, because everyone's going to be held to account in a much more targeted way on, okay, how did you get that from there to there, and why is that worsening, and what are you going to do about it?
Great. We might just move on if we can, because we've only got about 5 minutes and there's a whole slew of questions, if that's okay. I wanted to pick up on a question that is hinted at by several people online, which is the relevance of the Darzi shifts to what we're doing in both research. Now, we had a whole seminar on the SDEs and digital and data, so we don't have time to go over all of that today. But one of the specific ones, the question was about financial flows now being much more directed out of hospital towards home. So it strikes me before hearing, Hannah, from you, but there are good examples, I think, of our research efforts already trying to test the effectiveness of new technologies in one of the Darzi shifts, which is hospital to home.
Yeah.
Helen, Adrian, do you want to start?
Well, just so this is our digital health from hospital to home theme, which is a new theme this cycle in our BLC, where we are literally taking devices and wearables that we've developed in intensive care in particular and trialling them in the community to see if we can use them for remote monitoring to better select which patients should go to outpatients, which patients should be followed up more closely, which patients need to be reviewed in A&E or admitted to hospital, to really try and prioritise secondary care for those who need it the most and not recall patients routinely in a way that I think is hugely wasteful of resources. So there's a real potential there.
That's been very impactful research, and it's poised to then make a real difference. Yeah.
Well, and that's why we could collaborate together and do exactly that and move almost immediately from our proof of concept to deployment. Yeah.
Yeah, that's a great example. Adrian?
I was just going to make the point really that Ben's up there. You know, the SDE is a huge opportunity for us. And surely this is really about us trying to make the most of the population that we have. We have a very IT literate population. We have a population who are responsive to clinical research, particularly since COVID. And there are ways in which we can use those strengths not to really, as your large lab model, I like that, to ultimately really change things quite dramatically, I think. And it is really beholden to us, I think, to try and think of what our strengths are and put them into action.
So while you've got the microphone, Adrian, one question I had is how we could tap this huge living laboratory to increase the number of people who might want to participate in clinical research or specific individuals who are eligible for clinical trials. That would boost recruitment.
And that comes to, I think, partly my point about, I think people understand clinical research better now around Oxfordshire than probably anywhere else in the country. And I think people are proud of clinical research within Oxfordshire. I do think we need to try harder to integrate into the GP practices to make sure, I mean, there are good examples. Peter Rothwell's work, for example, looking at the incidence of stroke over 10 years in the community and great longitudinal studies, which ultimately have brought through a number of tools used by the NHS to manage patients with TIA and stroke in a much more cost-effective and clinically effective way. And that's a great example of how we can do that if we can get linking up primary care with the researchers, with our patients, to actually really make a tangible difference to the delivery of care.
Yeah, that's a great example. I suppose I might come back to Hannah or to Nick then. Are there examples that you can give us, Adrian's given us one, where you can already see, you've either got examples of or you can see real opportunities for taking advantage of research in what you are charged with delivering on behalf of the people of the patients of the ICS region? So are there already, spin-out companies that have come? Are there technologies? Are there patient flows? Are there pathways? Are there ways of triaging, etc., that you could already point to as showing the value of research?
Yeah, so I was thinking back to my time at Oxford Health and the use of virtual reality to treat people with anxiety and phobias of one kind or another. I think that is something that we really do need to look at how we can harness, how we can scale up at pace, not least when you think about the number of people who are currently off work through anxiety and other mental health conditions of one kind or another, and the lack of psychological therapeutic provision because of the lack of psychologists to deliver that provision. So how we can use VR, which can be delivered through people who are not trained psychologists, who are suitably supervised, is a real opportunity, and an opportunity, A, to improve services for patients, but B, to save some money. And after all, that's what we have to try and do. Improve care, at the same time spend less money on how we deliver care.
That's a fantastic strapline to end the conversation on, I think, Nick. We've used up our time extremely quickly. What a great session this has been. Thank you so much, Nick and Hannah, for a clear update and explanation of what I think is quite complicated. I now feel I've got a much greater understanding of how the ICS works, the responsibilities of the ICB, and how we can all work more closely. Thank you, panellists, for making time and contributing your extraordinary insights from everything that you do every day on behalf of partner organisations. Thank you to you in the lecture theatre at the John Radcliffe and to those many of you online who've taken time out of your busy days to join this seminar. And of course, thank you to Chris Bray and the whole of the JRO team for putting together the second of what is a very successful seminar series. It's really helpful to get people together and to focus on a particular topic of joint importance. On that point, I think we're looking forward to another seminar sometime in the autumn of this year, so watch out for posting, and you'll hear more about that in due course. There is an opportunity, I think, to give feedback, which should be on a slide. I don't have the slide here, but there's an opportunity, Chris, to give feedback on the seminar. People will receive an email, so look out for that. And with that, I'd like to thank you all once again for an excellent seminar.